Good afternoon again. So, as we know, there are lots of behavioural emotional problems in Prader-Willi syndrome, and so the question arises, to what extent do medications which influence behaviour, how helpful can they be in PWS? I think it's useful to think about different domains of behaviour problems that we may wish to be targeting with medications. There's the somatic symptoms, there's the emotional immaturity and the tantrums and the rages, there's the obsessional or perseverative behaviours that Dr. Foster was just talking about previously, and then there's the issue of psychosis and depression. So the somatic symptoms include the skin picking, the pain insensitivity, the excessive sleep, underactivity, and problems in temperature regulation. So I'll come to them last. The obsessions, the issue is that they're not solely related to food. So, so as others have pointed out, it can be about collecting things, it can be hoarding, and that we think of as the same kind of phenomenon as the perseveration, the repetitive questioning, because it's about being stuck with some theme or some idea and being unable to shift from that, being inflexible, and continuing with that to an abnormal degree. Now, the thing is that it's sometimes called obsessive compulsive disorder, but that's not really correct, and it's misleading to call it that. It's not the obsessive compulsive disorder that is a separate psychiatric condition which occurs in ordinary people who don't have PWS. In the obsessive compulsive disorder, strictly speaking, the person themselves recognises that their obsessions or their compulsions are irrational. They recognise that they're problematic. They often have they're often motivated by some kind of fear of untoward events happening if they don't carry out the obsession or the compulsion, and it often has a magical kind of quality. I mean, just to describe a classic case, which I remember, this is typical OCD. A woman who was telling me that she had to fold all the clothes when she put them away a certain number of times, because if she didn't, she had this fear that something terrible would happen to the family. And she knew this was absurd, but she couldn't help herself, and she'd just get overwhelmingly anxious if she didn't. I mean, that's classical obsessive compulsive disorder. And as you can see, that's completely different from what the PWS folks have, who don't view, of course, their thing that they're preoccupied or obsessed with as anything abnormal. It's the, you trying to interfere with them, that's the problem. Anyway, the point about it is, for the medications, the point about it is that the classical obsessive compulsive disorder does respond to psychotropic medications of the anti-anxiety type, and typically the so-called SSRIs, but other anti-anxiety types of medications, and they also respond to certain kind of cognitive behavioural interventions, and the point is that they don't work in PWS. So the reason I'm saying this is because if people assume that this preoccupation in PWS is the same as obsessive compulsive disorder in normal people, it leads them down the track of this kind of medication. And I have to say that the anti-anxiety types of medications, they usually don't have a lot of side effects, but the problem is they're just not helpful for the preoccupations of PWS. Now, the problem is, and this is true for much of what I have to tell you, we don't have good pharmacological treatments for the behaviour problems of PWS. and the kinds of strategies that just talked about in the previous session as ways, behavioural kinds of strategies are what we have to rely on for that problem. Okay, so with the somatic things, well, the only thing that for which there's any real some evidence of intervention is for the skin picking medications. There are a few trials which demonstrate that topiramate is actually mostly used as an anticonvulsant, anti-epilepsy drug, but it has a number of effects on thinking and behaviour as well, and there are some studies which have shown that it does reduce skin picking in Prader-Willi syndrome. So it's actually one of the few aspects of Prader-Willi syndrome which has been subject, to specific investigations. So that is certainly worth a try. It doesn't always help. There is also usually lower doses than are necessary for use in epilepsy. So one tends to start at the minimum. Now another one is N-acetylcysteine, which is a food, and you can buy it, through pharmacies or health food shops. You don't need prescriptions for it. I'll just come back to the topiramate for a moment. Topiramate is only available on the PBS for the treatment of epilepsy. It's not available on the PBS for the treatment of skin picking in Prader-Willi syndrome. So it's not enormously expensive, but it's not just for a prescription price. I forget exactly what the price is. It's probably about $80 a month or something like that. Anyway, N-acetylcysteine you can buy. There are a number of clinics report that N-acetylcysteine is useful for skin picking in Prader-Willi syndrome. I don't think there have been really good studies, double-blind controlled trials, but it doesn't have any significant side effects, and one can give that a try. And some people report it's helpful. Now, the psychosis issue in Prader-Willi syndrome, the psychosis is pretty common. Around at least 10 to 30% of folks with Prader-Willi syndrome develop psychotic symptoms. They usually develop in late adolescence, and they're significantly more common in UPD. So they're it's the most striking difference between UPD and deletion is the prevalence of psychosis. But it also happens in the deletions. So the symptoms are often paranoid kind of ideas, varying from just suspiciousness to frank delusions. One of my patients, for example, when he gets this problem, he has the view that the people going on the bus going past his house are saying things about him. Another young man has a view that when he gets this problem, that there's somebody outside the window who's threatening him, who wants to get in. So these kind of paranoid ideas, they're often prominent mood symptoms. That's to say, they may be associated with depression or with excitement and agitation, decreased sleep, being excessively happy. There may be some thought disorder, which means people aren't able to communicate in a logical sequence, and the thinking goes all over the place. Sometimes there can be hallucinations, so they can say they're hearing voices or seeing things. Now this condition has a remitting and relapsing course. It comes and goes. Fortunately, it usually responds very well to treatment, to antipsychotic medications, and there's usually a full recovery between episodes. So this is not schizophrenia, which is the other common psychosis, because in schizophrenia you usually don't get recovery and you get a whole lot of other chronic changes. But the folks with PWS, when they get over this, they're back to usual. And sometimes they do need ongoing low-dose antipsychotic treatment. So some of these folks I'm telling you about, when the problem arises, I increase the dose, and then when they get better, we try to reduce it again. And sometimes we find that it's fine for quite a while, but then we get below a certain dose and the problem seems to recur. So they have to stay on a low dose. Which antipsychotic medication? So the question's about can you stop treatment and you just keep continuing it? Well, the point is that this is coming really too in the next slide, but the point is that these medications are not entirely benign. They have side effects, and because they have side effects, that's why we try to reduce them. That's why we try to reduce them at every opportunity. Yeah. Well, it depends. It varies from patient to patient. Sometimes, one person with PWS will have a psychotic episode and they'll get over it, and they won't have another one for 5 years or 7 or 8 years, and that's quite a long time to be on a medication that's causing side effects. Whereas others that I've found that I try to reduce the dose and I get below a certain level, and every time we do that, they relapse. So it is rather variable. But these medications are, they're not benign. So the major problem, of course, is that most of these medications in the ordinary population, antipsychotics cause weight gain. And that's something, of course, we want to avoid in PWS. Now, I have to say that nobody, as far as I know, has studied what the effect of antipsychotic medications are on weight in people with PWS. And I've spoken to colleagues and nobody knows the answer. It's possible, I think it's just possible that there's so much else that's driving weight gain in PWS that the medications may actually have less impact than what they have in the rest of the population who are otherwise of normal weight. But that's just a speculation. But obviously anything that causes, at least even in the ordinary population, causes weight gain is something you want to minimise in PWS. The other major problem is that they can cause movement disorders. And so just to come onto this here, the various types. So the older ones are haloperidol or chlorpromazine, and then there's a whole range of newer ones: amisulpride, risperidone, quetiapine, Zyprexa. There are others. Every company, has got its own brand on the market, and they modify the molecule slightly, inevitably claim that their modifications made a huge, associated with huge benefits, but mostly it hasn't. It's not really very different. But the older ones caused more of the movement problems. So the movement problems are tremor or involuntary movements, for example, movements of lips. And that's usually only of a nuisance value, but it's better off if you don't have it. The newer ones cause less of those movement problems, but tend to cause more weight gain. The other problem is that they cause hyperprolactinemia. That's to say, prolactin, which is the hormone that is secreted when mothers are lactating, is increased. And I'd have to ask our endocrinology colleagues here would be able to advise better than I whether increased prolactin is likely to be a problem in people with PWS. In ordinary people who don't have PWS, it's a problem for girls because it gives them breast engorgement and even can cause lactation, and it's not good for boys because too much prolactin has adverse effects on the development of the testis. But whether those things matter in PWS, I'd leave to my endocrine colleagues to advise you. But anyway, the point is that these things, you need them for the treatment of psychosis. The patients are much better once the psychosis gets better, but we use the minimum we can get away with. Okay. Now, depression, as it turns out, is less well known and less well studied in Prader-Willi syndrome. But one of the studies of prevalence was one we did, and we found that major depression was actually more common than psychosis was. That's it's usually episodic, and it tends to respond to standard antidepressants. I tend to use sertraline because it's has, in my experience, the least side effects, but there's no real evidence that one works better than the other. And sertraline doesn't have any effect on weight. So that's the depression side. Now, the big issue, the big behavioural problem is the temper tantrums or the rages. And the problem is that no psychotropic medications have been shown to reduce or moderate the rages or the tantrums. And indeed, the oxytocin study that I described to you earlier was really motivated by this. The medications, the ordinary psychotropic medications we have not done much to help reduce the tantrums and the rages, and we had to look at something further to try to do that, and that is driving the search for better behavioural treatments for PWS. And in particular, antipsychotics or major tranquilizers usually don't help. And if I had to make a generalisation, I would say that there is far too much antipsychotic or major tranquilizer prescribed, across the board for people with PWS. There's much too much taken in if you take into account, the evidence that it doesn't work. Now, why is that? Why is there so much prescribed? Well, the point is that for many other problems, in people with developmental disabilities, for example, children with autism who are highly agitated, people with other causes of intellectual disability who have a lot of aggressive or disruptive behaviours, these kinds of medications often are helpful. And in autism, for example, there's a substantial body of evidence that irritability and behaviour problems are reduced by risperidone, one of those. So, when you go to see the doctor or the psychiatrist, it's natural that they think, not knowing a lot about PWS, they think, well, I've got other patients with developmental disabilities who've responded to this. It's causing a lot of problem, a lot of stress for families, a lot of stress in group homes for carers. We've got to do something, so they go for that. So it's natural that they do so. But you need to know that the evidence is not there to support it. Now, this is really just from my own experience, and there is some theoretical basis for it, but carbamazepine, which is also an anticonvulsant, I have found sometimes helps to reduce the frequency somewhat of tantrums. I wouldn't say that it makes an enormous difference. So to me, you know, here in 2015, I have to say this is the biggest gap, you know, in treatment of PWS. If there was something I could do to make, you know, the lives of families easier, it would be to find a drug to reduce the tantrums. Now, having said that, your doctors may want to try out various psychotropic drugs, and you know, you can do that, and there's nothing wrong with doing that. And when we talk about the evidence for effectiveness of drugs, you know, we're talking about their effectiveness across a whole group. There can, of course, be individual variation, and there may be, you know, individuals who respond when the majority don't, and there may be a minority who don't respond when the majority do. So the point is that if things are going to be tried, you have to have a way. What's important is to have a way of measuring whether what you do, whether what's prescribed is useful or not. If you don't have a systematic way of doing that, then you find that you know, the person, there are all sorts of medications are experimented with, but you can never really reach good conclusions as to whether they were helpful or not. And I often see patients who've been, you know, tried on 5 or 6 different psychotropic medications, but there were never proper trials, and so you never really knew whether they were working or not. Now, one important component of doing a proper trial is that you have to have some kind of systematic way of measuring whether a medication is working. And the problem is that, you know, typically people don't use very systematic ways. You know, you go along to the doctor and the doctor says, well, you know, I've prescribed this drug, and, you know, is Johnny any better? If it's a parent, the parent will say yes or no, and we'll give a view. But we know that, and I mean that's easy. That's easier. If the person is residing in a group home, and you know, there's a carer who comes along, and it's not the same carer who came along last time, and everybody's got a different recollection, a different view, a different opinion of what it is, it becomes extremely difficult. But even with a parent, you know, where there's only one reporter, you know, we know that kind of casual reporting is subject to all kinds of biases. You know, there's the so-called recency bias. You know, if you haven't been along to the doctor for 6 months, the doctor says, "How's Johnny going?" People report how they've been in the last few days, not how they've been over the last 6 months. And then there's the so-called saliency bias. You know, it's the people remember the important things about the behaviour. You know, if Johnny with PWS, you know, throws something and doesn't hit anybody 10 times, well, you know, okay, it's a bit of a problem. If he hits somebody, if his aim happens to be good once and hits somebody and hurts them, then people will report the behaviour as much worse, even though it's actually identical behaviour. The only variation has been in the person's aim quality of their aim. So, you know, that's the so-called saliency bias. If they break something, you know, if they break something which has got no value, people say, oh, the behaviour's not too bad. Smash something which is, you know, a family heirloom, same behaviour, they'll report the behaviour is terrible. This is normal. These are normal biases in this kind of reporting. It's not due to any deficiency on the part of the reporter. So what we use is we use a systematic way. So this comes from an instrument to measure behaviour in children with developmental disabilities, which I developed about 20 years ago, the Developmental Behaviour Checklist. There are others, but this is one you can use. And we use a version called the monitoring version. Sorry for the misspelling there, Lauren. And what we do is this has normally got 95 items. We pick out 5 items. Now this one wasn't constructed for somebody with PWS, but I see number 4 is stealing food, so that bit might have been maybe number 1 and number 2. What you do is you score every day, and if it was not a problem today, you put a 0. Somewhat of a problem, you put a 1. Major problem, you put a 2. And then you get a weekly total. If it was terrible every day, it's a score out of 14. It's going to be 14, 7 times 2. But the point about it is that you are doing this contemporaneous with the behaviour. You're doing it on a daily basis. And the other problem, especially with group homes, and Damien over there, who's an expert on this, knows very well that the way effects are usually, especially with behaviours, are usually measured is with incident reports. The problem, incident reports have a substantial false negative problem. If there's no report, you don't know whether that's because the carer was too busy to write something down, or it could have been the behaviour and somebody had such a terrible behaviour, there was a crisis, they didn't have time to fill it out, or because actually nothing happened. So the point about this is that if nothing happened, you have to put a 0. And if there's no 0, if there's nothing there, that's missing data. You don't confuse it with 0. And it's also being done on a daily prospective basis. And then you can put this on a graph, and you can see. So here along the bottom line, you've got the weekly totals, and up there you've got the score up out of 14, and then you can just graph it. Now, if this is showing you that from start to finish over about 12 weeks, there's not much benefit. So at least you know that. If the treatment is working, the line should be going down. So so this is one way which I think I would commend to you, whenever you're trying out different medications, and this is inevitably what will happen when we've got a field where we don't have clear drugs which clearly address the problem, and we are having to experiment with various things, that you use some kind of systematic way of determining whether what is being tried out is helpful or not. So I'll finish on that point, and perhaps if there's any questions, if there are times, is there time for questions? Okay.
Do you find episodes of psychosis are linked to periods of stress?
Look, in my experience, I think that does happen, but I'd say even more often it just comes out of the blue and nobody really knows why it's come back again. The other thing I was just going to say about the symptoms, sort of about the paranoid stuff, it gets a bit. Sometimes it's very clear cut. Somebody's complaining that the people on the bus going past the house are talking about them, but sometimes it's not so clear cut. Like when there's a complaint that other people in the day activity centre are talking about them behind their back. Well, it could be right, So you've got to know it's only when I get to know the person very well, and we've seen that this is an episodic thing that happens repeatedly and it gets better with the medication. He doesn't worry about him. Then we know that it's part of the paranoid psychosis. But some other times you mightn't be so sure.
2 questions, if I may. The depression you mentioned is episodic as well. Just similarly with the you said that the depression is episodic. So do you think early on one should aim to stop treatment there as well? I guess I'm asking these questions because I look after adults and they're on numerous psychotropic medications, and I often wonder why. But I'm a little bit anxious to stop. Well, I certainly don't rush to stop anything. But it would be nice to have some assurance that I can gradually reduce doses.
I don't continue any psychotropic medication indefinitely unless it's been demonstrated to me convincingly that on several occasions when I've tried to reduce it or stop it, that the outcome's been worse than the risks associated with continuation. So the basic line is I always try to reduce or stop everything. But the point is that the SSRI, the side effects of the SSRIs are substantially more benign than the side effects of antipsychotics. So the pressure, if you like, to reduce that is less. And, I'm not so bothered if they're on it for 6 months. And generally speaking, the recovery from major depression in the general population is the natural history of depression is that major depression lasts for 6 months. Whether that's true in PWS, I don't think there's been enough. As I said, the psychosis has been heavily researched, the depression less so.
And the next question, the developmental behaviour checklist you talked about, it sounds, if I understood correctly, there isn't a specific one for PWS, so do you select behaviours that are a problem and ones that you think are worth monitoring from your big list? Is
Correct.
that how it works?
Yeah, well, if you have the software,
Right.
you just click on the items that are what you would regard as the targets for your treatment, or if they reflect particular side effects that you are wanting to monitor, then you pick those out. You can make up your own items. It's just that the ones in the checklist have already been checked for their inter-rater reliability, which means that it's already been demonstrated that 2 different raters will understand the same thing by that description.
And is that something that you need to purchase, or is it readily available?
You have to purchase it. It's not free, but it's cheap. And it's not for profit. All the proceeds that come from people purchasing it go back into developmental disability research. It costs $1 per questionnaire, and the software, I forget what it costs. It might be about $60, and then the software will generate the DBCM, the monitoring version, and it will do the scoring and draw the graphs for you.
You finished? Stuart, thank you for that. That was great. I just wanted to know, has there been any link between talking to an imaginary friend in a child or talking to themselves? My daughter talks to herself constantly, and psychosis, and she's got UPD, so I'm just wondering if there is any, follow-up.
Oh, look, I think that's an excellent question, because people with PWS have some deficits in social skills, as do many people with other developmental disabilities. And a common deficit in social skills is to voice your thoughts or publicly.
Yes.
Some of us talk to ourselves, but we usually don't do it aloud because our social skills have been such that we realise that it's not a wise thing to do. But I talk to myself. If there's some really critical conversation that I'm having am anticipating, I might rehearse it.
Yes.
This behaviour is very common, and in people with developmental disabilities, and of itself has nothing to do with hallucinations. It's often people will often go over incidents that have happened to them that are emotionally important to them, that matter, or and the only thing that is abnormal about it is that they're doing it aloud instead of saying it to themselves. So yes, it's very important for one of the things a psychiatrist has to do is to distinguish between, the social deficit of voicing fantasies often, or it could be just fantasies, or rehearsing, incidents that have happened, and distinguishing that from a true hallucination. And And as a consequence of that, I have to say, where people, as a consequence of that, antipsychotics are generally overprescribed to people with developmental disabilities because people frequently mistake that behaviour for a true hallucination. But true hallucinations have some different properties and qualities.
It's very clear. It's like Mum says, you go to the taps and then you get your toothpaste and then you put the toothpaste on the toothpaste. It's just saying the whole thing out loud.
Yeah, and that has no prognostic. I think that's your question. It has no prognostic meaning. It does not mean that the person is more likely to develop, a true psychosis and true hallucinations.
It's actually Joe's kind of beaten me to it a little bit. I noticed that you've put the range of age from 9 to 40 when you're dealing with a child, and Joe's just sort of asked you that question, and mine was along those lines of how do you recognise when a person's gone from fantasising and child's play to the next step, I guess, is a psychotic episode, I suppose, and as a parent.
Yeah, well, when the person develops psychosis, they are when it starts and when it's it's kind of comes on gradually, sometimes over over a week or a couple of weeks, and when it's just coming on, sometimes it's not very clear. But once it's there, it's quite clear because the person is manifestly unwell. They're agitated. They're distressed, atypical, which is not usual for them. They're not, they're going to a day activity centre or work. They're suddenly not functioning. They're not able to do their jobs. They've got, their sleep is often suddenly disturbed. So, the delusional ideas are part of a whole syndrome of illness. It's quite clear that they're not their usual self and they're not as well as they are usually. What do you think? Is that your experience, sir?
Often non-professional people will know if someone is hallucinating. You'll be able to ask the person who cares for someone, does it feel like they are seeing or hearing something that's not there? And very often, a parent or caregiver will be able to say yes. It really feels as if they're seeing, and that's a hallucination is something that their brain sees as normal, but the rest of us can't see. And when they're hearing something, it sounds exactly like a real sound, but no one else can hear it. And so when you're with someone who's experiencing those things, you really, even though you've got no training in the area, people are often able to say it feels and seems very different, and people's whole personality changes. They become often quite withdrawn and agitated, and there's a qualitative change. And sometimes for people who are in supported accommodation who don't have family with them, it's harder for carers to pick that up if they don't know them well. But if someone knows somebody well, they will be able to say, this is not what this person is normally like. And it's really becomes, the more unwell they get, the more clear it becomes.
Okay, thanks very much. Another question?
Last
question.
Sorry. I'm interested in whether you have any experience or comments about the use of stimulant medication for children with excessive sleepiness.
Are you referring to modafinil or are you referring to
Modafinil or
methylphenidate?
Methylphenidate.
Dexamphetamine? Well, look, firstly to talk about methylphenidate and dexamphetamine, the major problematic side effect of those medications in children with ADHD is that they suppress appetite and suppress growth and weight gain, and so you would think that this would be a terrific candidate to use in PWS, and indeed it has been used, but there've been no clinical trials, which I think is very surprising, and I know of one which has been proposed, and I think it's overdue. But I'm inclined to think that, you know, it's such an obvious treatment to try, and it's so common that if it really made a big difference in PWS, I'm surprised that we don't all know about it. But nevertheless, it's going to take a decent clinical trial to sort that one out. So the answer to that one is, you know, we don't know. I haven't seen any. I don't know if anybody else, but I haven't seen any studies of modafinil for the daytime sleepiness of PWS. You know, it would be, again, it's a logical thing, but of course much newer, but it's a logical thing to be tried. But is anybody aware of any clinical trials of modafinil? Yeah, so it's used for narcolepsy, and if the child has got actual narcolepsy, you know, it could be tried. Yeah. All right, one last. Look, the question is about fluoxetine for the treatment of anxiety. I don't find anxiety to be, to a psychiatrist, anxiety is a very generic term. It's a very broad and sort of nondescript term. I would need to know more about the symptoms to know exactly what people are describing when they're referring to, you know, a person having anxiety. You know, there's a lot of anxiety around food. You know, that's one phenomenon. There's anxiety if you don't respond in some kind of a way to the, you know, preoccupations. You know, that's a different problem. My inclination is that I haven't seen much benefit from the fluoxetine or that class of SSRIs in PWS, except for the treatment of depression. Now, that's not to say. That's not to say that there aren't individual patients who have benefited, and that's, you know, we need to. Another thing we need to understand, when we do the clinical trials, we're referring to a group outcome. And the reason, you know, we refer, so, you know, the group who got the placebo versus the group who got the drug, you know, if you compare the average of the two, did they do better? And the reason we do that is because that's what gives us the predictability. So if a person comes along and says, my child's got PWS, will they benefit from this? The advice you give has to be based on what the majority outcome was. But that doesn't mean that an individual might not respond, and it's a judgment. To answer the question, you know, the title started with, you know, do you use it or not? It's a judgment to weigh up the potential benefits against the potential disadvantages, and that's so, you know, you try things not only taking into account the severity of the problem, but also the risks and dangers associated with the trial, but also, as I've pointed out, the requirement to make sure that you're monitoring the outcomes well. So I think I have to stop there.